Good day to all of you joining from across the globe. Before we begin, I'd like to remind you, everyone, that the session is recorded, and you can also choose your preferred language from the translation. You can put the questions and comments in the chat or your Q&A box. So let's start. It's my great pleasure and honor to introduce Dr. Agnieszka Czechowicz. Professor Czechowicz is a physician scientist at Stanford University School of Medicine, the Department of Pediatrics, specializing in hematology, oncology, and stem cell transplantation. She's also affiliated with the Stanford Center for Degenerative Medicine and the Stanford Institute for Stem Cell Biology. Her lab focuses on hematopoietic stem cells, aiming to enhance their use in treating blood and immune diseases. She has pioneered research on stem cell depletion for donor engraftment and is developing therapies to eliminate chemotherapy from transplant protocols. Dr. Czechowicz is particularly interested in bone marrow failure syndromes, including Fanconi Anemia, and has led innovative gene therapy trials. She has received multiple awards for her contributions and is dedicated to mentoring future physicians and scientists. So, Professor Czechowicz, the floor is yours.
Thank you so much for the opportunity to speak today. Give me a second. Let me pull up my slides. All right, can we see those?
Yes.
Wonderful. So today I'll be talking about our work on innovative cell and gene therapy approaches to improving outcomes for patients with Fanconi anemia. As was introduced, my name is Dr. Agnieszka Czechowicz, and I'm an assistant professor of pediatrics in the Division of Hematology, Oncology, Stem Cell Transplant, Regenerative Medicine at Stanford University School of Medicine. And I'll be talking about our work on Fanconi anemia, but there are a lot of parallels to sickle cell, which I'll touch on at the end. And then I will try to leave time for questions so that I can answer any questions that the group may have. These are my disclosures. So today I'll mostly be talking about hematopoietic stem cell transplantation, which is a wonderful procedure that can be used to cure so many different diverse blood and immune diseases. The way this procedure works is that it utilizes healthy hematopoietic cells, often from the bone marrow, or more commonly now from mobilized peripheral blood, or sometimes from cord blood, most often from a donor, but we can also use patients' own cells that are gene-corrected. And we use these healthy hematopoietic cells to recreate a brand new blood and immune system that can persist for the life of a patient. And we literally transplant these cells through an injection into the intravenous system, and they have this remarkable capability of knowing how to get back into the bone marrow and recreate a brand new system. This is not something that's theoretical. It's something that's been performed for dozens and dozens of years now, with over 1.5 million patients that have been treated to date, according to a review article that came out a few years ago. So now I'm sure we're even at higher numbers today. Now, these hematopoietic cell transplants have lots of different names. Sometimes people call them hematopoietic stem cell transplants, hematopoietic cell transplants, bone marrow transplants, which sometimes have different connotations, but often are used synonymously. But there are these unique procedures that are really enabled by cells called hematopoietic stem cells, which are the stem cells that generally live within your bone marrow, that have the remarkable capability to be able to self-renew and give rise to more of themselves, as well as differentiate into all different types of blood and immune cells. So these hematopoietic stem cells were naturally born with, and they have this ability, again, to recreate an entire blood and immune system when they're transplanted, which gives them this powerful capacity and enables hematopoietic cell transplants to ultimately be curative for so many different diseases. On the right side of the slide are just some of the many different diseases that hematopoietic cell transplants have been cured by. And what you can see on this list is there's a lot of different blood and immune diseases, from inherited blood and immune diseases to malignant and of various different types. And again, that's because these cells have the ability to recreate all of these blood and immune cells. And so any of the diseases of the blood and immune system can be cured through a hematopoietic cell transplant, as all of these blood and immune cells get replaced in this procedure. Now, I wish it was as easy as it was shown on the first slide. This slide shows us some more of the complexities, but really I want to highlight that these are really complicated procedures. There's a lot of different components that are involved in this, which is illustrated on the left side here. And these procedures can also have, unfortunately, severe toxicities. And because of these two components, this is why so few patients ultimately get transplanted today, despite the number of patients who could benefit. On the left side, again, is still a high-level schematic of the different components of a transplant, but there's a lot of steps to this. This often involves patients staying in the hospital for several weeks, if not for several months. And there's a lot of different medications that we use. And patients can, again, get very sick during the procedure. And in particular, prior to a transplant, there are specific medications that are used called conditioning. And what conditioning is the preparation of a patient to be able to receive a stem cell transplant. And the way that we do this today is with high doses of chemotherapy and or irradiation that are given to the patient prior to receiving the transplanted cells. And while we're appreciative that we have these types of transplants and the medicines that we have can work very, very well, they can have a lot of toxicities. And so that's where my research has been in particular focusing. And then another aspect, unfortunately, is not just the complexities of these procedures and the toxicities up front through the conditioning, but unfortunately also patients can have different side effects, some of which are listed on the right side, which can be particularly damaging. Certain side effects can be graft versus host disease, which can be a very challenging reaction that donor cells can have on a host. Now, this doesn't occur in the gene therapy setting, but it can occur with transplants from a healthy donor. Patients also can get serious infections, bacterial infections, fungal infection, viral infections as examples. And then they also can get tissue damage from these types of transplants themselves. Here kind of represented by hair loss, but unfortunately all of the tissues can be damaged to certain degrees. And all three of these side effects really can be triggered by the conditioning that we use. And so that's why our research efforts are really focused on the conditioning piece. One, to decrease the complexities of a transplant. Two, to decrease the upfront toxicities of conditioning. And then three, to ultimately decrease the long-term toxicities from conditioning. And by doing so, we would hope that then more patients can benefit from stem cell transplants. And our ultimate goal for these types of therapies is to enable 100% survival and 100% cure rates from these procedures, because unfortunately, we're not there yet today. And then in addition to that, our hope is to have no short-term or no long-term toxicities. Again, by replacing the toxic conditioning that we use today, this chemotherapy and radiation that is a standard part of transplants, with ultimately better approaches. Now, my research in this area started when I was an early trainee, initially really as a graduate student in Professor Irv Weissman's lab at Stanford University. Professor Weissman is one of the pioneers of hematopoietic stem cell science and helped really understand and purify and identify the hematopoietic stem cells that have this remarkable capability to be able to be transplanted and give rise to a new system. And when I was a trainee in his group, we were starting to understand what are the barriers to stem cell transplants and why do we even need to do conditioning, because that was not as well understood. And we had really had two thoughts: that conditioning most likely was needed for immune suppression, so to prevent an immune reaction from the recipient to be able to allow a donor graft to engraft. But that also maybe your own stem cells were competing for space in your bone marrow with the new stem cells. And people had long thought that in general you needed an empty bone marrow from conditioning, but we really wanted to look at what specific cells potentially were problematic. And so we did these experiments where we transplanted purified stem cells to try to understand, could we just give more purified stem cells in a setting with no immune system? And could those engraft? And what we found is that a small number could engraft, but they really couldn't engraft at higher rates no matter how many we gave. And we saw this kind of saturation rather than replacement. And when we started to look even more carefully and plotted the engraftment efficiency on a per cell basis, we found that the more cells you give, the less likely on a per cell basis they are to engraft, likely suggesting that your own stem cells compete with space for the transplanted stem cells, or transplanted stem cells compete with themselves. And this really gave us this thought that maybe if we got rid of your own stem cells, this could create more space for a transplanted graft. And that's what really opened up this entire field of HSC-targeted antibody conditioning, thinking about rather than creating space in the bone marrow broadly, which is definitely what our current methods do, which is why they're so effective. But could we actually do something more targeted and maybe not have to create an entirely empty bone marrow through this conditioning process that we use today with chemotherapy and radiation? But what if we used specific approaches that could just get rid of your own stem cells in a unique manner? We started to do this with antibodies, which are proteins that your body naturally makes to try to protect itself against different infections. But we really re-engineered those to think about designing ways that we could use antibodies to deplete inherent intrinsic stem cells in the recipient so that they could then undergo a stem cell transplant without chemotherapy and radiation. In order to do this, we had to initially pick a target on stem cells and selected this protein called CD117, which is a receptor for an important cytokine that stem cells need called stem cell factor. And so this was kind of our idea and what we've ultimately now been developing over a couple of decades to develop HSC targeted approaches to conditioning. First, we of course had to do proof of concept studies to see if this kind of an idea could work. And initially, we started with antibodies that are antagonistic, which means that they prevent the binding of their ligand. And specifically, again, I mentioned we're using antibodies against CD117 or c-KIT. So the initial antibody that we used really inhibited the binding of its ligand stem cell factor, so really depriving stem cells of an important growth cytokine that they needed. And then later on in my postdoctoral work at Boston Children's in Derek Rossi's lab in collaboration with Professor David Skadden, we started to work on antibody drug conjugates. So these are antibodies that have really been linked to a toxin, so the toxin could then kill the stem cells. And in both of these settings, what we found is that a one-time dose of these types of antibodies could deplete the hematopoietic stem cells. And now when we gave these stem cell transplants, we could get much higher rates of engraftment, much higher amounts of engraftment, really showcasing that we overcame this engraftment barrier. And now we are able to get high donor chimerism with just antibody-based conditioning without the need for chemotherapy and radiation, which was pretty amazing. We also showed that we could do this against other proteins, and we showed that this is a way to select stem cells over other cells, really giving us all sorts of ideas on how we could innovate and build upon this with time. But these were really the proof of concept studies that showed that as a principle, this is an approach that could work, at least in mouse models. And what was really exciting is that these approaches seem to be significantly safer than chemotherapy and radiation, which is what we would have hoped and expected. And in particular, all the things that we could see with classic conditioning, we didn't see with these types of antibodies. And the tissues generally looked very healthy. And what you can see just in this picture of two mice is the mouse that received radiation looks pretty sick. Looks hunched over. Their fur is grayer and is thinned, whereas the mouse that had been treated with our antibody drug conjugate looked totally normal and very healthy, which is again very exciting to our group. Now, each of the antibodies that I mentioned did have some toxicities, so I don't want to make it seem like they were completely safe and benign. The antagonistic version caused some transient graying and some whitening of the fur of the mice, and that's because the target that we selected, CD117, is also on melanocytes, and so those cells were affected by the antagonistic approach. And then the antibody drug conjugate didn't cause the graying, despite targeting the same target, but it did cause some increased liver enzymes that were transient. But in both of these settings, otherwise, these mice were fine. They were also fertile afterwards and were able to give rise to litters of pups, which is something that after chemotherapy and radiation, unfortunately, mice and people can struggle with. So then we started to think about how could we use these antibodies in potentially interesting translational settings. And one approach that we did is we started to combine antibodies with gene-modified cells. So again, as I mentioned, most transplants today are with patients' patients receive stem cells from donors, so they're donor transplants, otherwise known as allogeneic transplants. But it is possible to, in some cases, use patients' own stem cells that are gene corrected. Now, this can be done with viruses or CRISPR systems or newer approaches like base editing approaches. And so we've tried to model that in our mice here with our new conditioning regimen using the antibody drug conjugate. And what we showed in these proof of concept studies, initially here with gene-modified cells that could now be gene-modified to make a hemophilia protein, we were able to get engraftment without the use of chemotherapy, and that these new gene-modified cells in this particular mouse model could actually now create factor, and so these mice were cured of their hemophilia. And again, this is just one example, and the idea here is that you could modify these mouse's own stem cells now to do all sorts of interesting things, but again, putting them in with the antibody-based conditioning. The other thing that we did is we wanted to model the use of our antibodies together with immune suppression to be able to do transplants from a donor mouse, and in particular a donor mouse that wasn't immune matched to the original mouse. And so this is really modeling these types of donor transplants or allogeneic transplants. Here we used our antibody drug conjugate in combination with a lot of different immune suppressant agents to, again, turn the immune system off and to get rid of the mice's stem cells to kind of overcome both of those barriers simultaneously, using an all antibody-based approach, again, with no chemotherapy and radiation. And here we showed that this approach now enabled us to get engraftment of completely mismatched grafts. And then, interestingly, we also were able to do a skin graft at the same time from the donor mice and showed tolerance. And that's something that had been shown previously with bone marrow transplants, but we weren't sure if that could be done with our all antibody approaches, and it did. And also, very excitingly, we saw no graft versus host disease in this model, despite, again, using completely mismatched grafts. And so those are kind of two examples of how we think these types of antibodies can be used, and two of the types of antibodies that we've developed over the time. Now, since our initial work in this area, there's really been an explosion of efforts on antibody-based conditioning. These are just some of the publications that are now emerging in this space, and so I'm very hopeful that others continue to work on this as well, that we learn more about how these types of antibodies can be used and develop different types of approaches, and then apply them to a lot of different settings, such as sickle cell. Now, a lot of our work is really focused in the mouse system and trying to, again, develop these as proof of concept agents. But we've also been working with different companies over time to try to develop clinical agents. And this is just a slide that highlights some of the approaches and some of the groups that are now working on this. Some of these are more advanced, some of these are earlier. Some of these have shut down either because programs didn't work or the companies, unfortunately, didn't have the resources to keep building upon these. But I'm very hopeful that eventually we'll have a lot of different agents that can be used in these different ways, just as we have for our mice, because different agents have different pros and cons, different toxicity profiles or different ways that they can be used. But we are making progress towards this today. Now, while these companies have been making different types of drugs and slowly working towards clinical development, my group has really started to focus on how we can apply them and selecting an initial disease that has really become our focus area. And specifically, we've selected this disease called Fanconi anemia, which is an inherited blood and immune disease that is caused by defects in proteins called the FANC proteins that are involved in DNA repair. And so patients who have mutations in these FANC proteins, unfortunately, don't have the same ability to repair DNA that naturally can have breaks due to exposure to different agents or just to age and to inflammation. And a majority of these patients, unfortunately, develop bone marrow failure, most commonly in their early childhood years. Again, because this is an inherited blood and immune disease, it can be cured through hematopoietic cell transplant. On the right side, you can see kind of the survival curves of these transplants. It's wonderful that as a field, these types of transplants have been getting better, but still, there are some patients who don't survive with the way that we do our current transplants. And then, of course, these patients have toxicities, as I mentioned. But the other thing that can happen after a stem cell transplant with the way that we do them today with chemotherapy and radiation is patients can get cancers, and that can be a very real and challenging long-term side effect of these types of transplants. And in patients with Fanconi anemia, unfortunately, because they have DNA repair deficiencies, they already have a very high rate of getting cancer. And after the way that we do transplants today, these patients have even higher rates of developing cancer. So unfortunately, almost 100% of patients with Fanconi anemia who undergo standard of care stem cell transplants, which again they need because they develop bone marrow failure, which causes them to no longer be able to make their own blood and immune cells, almost 100% of these patients develop cancer between the ages of 20 and 40, which is really challenging for these patients and their families. And so this particular patient population had a particularly high unmet need, and these patients are particularly vulnerable, which is why my heart went out to them and why our group wanted to really start to work on applying our antibody-based conditioning methods to this patient population, as well as thinking about other approaches that we can work with or develop to try to help these patients. So initially, to start to translate our work into Fanconi anemia, we wanted to compare our different methods that us and others have developed over time, and we did this in Fanconi anemia mice. This work was led by one of my trainees, again, to compare different types of antibody-based approaches. And then we also wanted to look at what's happening to the gene expression of these cells to understand if there's any issues with DNA repair caused by these antibodies. And what we saw is that both we saw engraftment with these different types of approaches, although to differing degrees, depending upon whether we used a drug conjugate or a naked approach. And then we saw no significant gene expression changes. So this gave us reason to believe that both this could work and that this could be a safe approach. And so this ultimately led us to start to think about how we could design a clinical trial to help patients with Fanconi anemia and really push the development of antibody-based conditioning forward for patients. And so we've used the first generation and the first clinical anti-CD117 antibody that has been used in a transplant setting, combined with donor hematopoietic cell transplants, and specifically donor grafts that have been manipulated using this approach called TCR alpha beta T cell CD19 B cell depletion. So again, we're using our antibody in place of irradiation or a drug called busulfan, and then we're using these donor grafts that actually come from mobilized peripheral blood from healthy donors that are manipulated in this type of way to decrease for graft versus host disease and help with fighting infections. And then we closely monitor all the drugs that we're using. Now, we can't just use this antibody alone in patients with donor transplants, as I mentioned, because we also have to get rid of the immune system to not have immunologic rejection. And so this is ultimately what our clinical trial schema has looked like, where we've also been using immune suppression together with our anti-CD117 antibody that now has this name, briquilimab. The immune suppression that we have available today, unfortunately, still involves some chemotherapy as well as some antibodies. So it still does have fludarabine and cyclophosphamide, which are two different chemotherapeutics. So this still, again, has some chemotherapy, but it's a much lighter protocol because now we don't have any irradiation or busulfan by replacing that with the antibody. And then this clinical trial we opened a couple of years ago. The sponsor of this trial is our director of our Center for Definitive and Curative Medicine, Dr. Matt Porteous, and then my clinical colleagues, Dr. Rajni Agarwal and Dr. Lijay Bertaina, have been leading the treatment of patients. And we've been very excited to have a protocol that seems to work really nicely, which has been great. And specifically, what we've shown in this clinical trial is that the antibody that was given to these patients cleared at a consistent rate, and that when we transplanted these patients with donor cells that we actually obtained from their only half-matched donors, so in this case, almost all of these patients received grafts that were either from their parents or siblings, which can be much harder grafts to be able to use, but we were able to do this effectively in our patients, get really nice grafts that engrafted quickly with recovery of the blood and immune system in these patients within a couple of weeks. And now these patients' blood and immune system was almost completely from their donors, and they no longer had bone marrow failure. Now, again, because we're still using some chemotherapy and because these types of transplants still aren't perfect, even though we're continuing to work to improve upon them, we did have 11 of 12 patients that had prompt engraftment, but one patient unfortunately still passed away from this type of procedure. And then our patients still did have mucositis, which can be a challenging reaction, but still these types of outcomes are so much better than they used to be. And so we're hoping to be able to expand this type of regimen to more patients and to really continue to innovate upon it and continue to improve to ultimately try to make these types of transplants extremely safe and effective. And so this is really one step forward. Now, this clinical trial that I mentioned using antibody-based conditioning is just one clinical trial in our portfolio of trials for patients, and I thought I'd just briefly mention some of the other ones. So again, our original way of treating patients with transplants from donors with irradiation or busulfan-based approaches, as well as immune suppression. We opened this clinical trial with our antibody-based approach, and then we also have two other clinical trials that we're working on. One is on autologous gene therapy, so again, taking patients' own cells, correcting them, and giving them back. And then the other is a new program on in utero transplantation to try to correct this disease before patients are even born through a collaboration with our colleagues at UCSF. Now, first, I thought I would just talk about our gene therapy approach briefly. This is a collaborative clinical trial that really started off of work that was initiated by the CMET group in Spain and now is being developed by a company called Rocket Pharma. And so we've been one of the clinical trial sites and partners in this program, but it's really been a global program trying to treat patients with Fanconi anemia with gene therapy. And the way that this works is we identify patients earlier in the disease process before they have significant bone marrow failure, when they still have significant numbers of stem cells that can be corrected. We give them two different drugs, G-CSF and plerixafor, that push the stem cells from the bone marrow into the peripheral blood. We then collect these from our patients through a process called apheresis and then purify them with an enrichment process. And then these cells are gene modified with a lentivirus, which is an engineered HIV virus that can now give back the missing gene. Because we're giving back a gene, this approach only can be used for patients that have deficiencies or defects in that specific gene. And so this particular clinical trial is only available for patients with mutations in the FANK-A gene. But it is an approach that we can potentially use to stabilize the hematopoietic system for the FANK-A subtype of Fanconi anemia. And this can be a much lighter and easier treatment than the allogeneic donor transplant because we're able to just use these mobilization drugs, and we've been able to do this without any conditioning whatsoever due to some research that seems to suggest that corrected stem cells within Fanconi anemia systems actually have a competitive advantage over the fragile Fanconi anemia stem cells. So this is something that's very unique to this disease and not true of many other diseases, but has created a unique way to be able to potentially do gene therapy for these patients without the need for any conditioning. And what we've seen in these patients is that we've had a nice engraftment of the gene-modified cells in a majority of patients that continues to increase with time and really stabilize the blood immune system in these patients with minimal toxicities, which has been very exciting. Now, it hasn't worked in all patients. We're still following these patients. Not all of their blood and immune cells are ultimately gene corrected. So we're still learning about exactly how this works, how we can improve upon it. And then unfortunately, this has only been available on a clinical trial, and we're still working with our clinical trial partner, Rocket Pharma, to be able to develop a commercial approach that can be used for more patients. So hopefully more to come on this with time. And then the last program that I just wanted to introduce is on our work on in utero transplantation for Fanconi anemia. So we had this idea that potentially we could transplant patients with Fanconi anemia even before birth, because during fetal development, the immune system is still fairly naive. And so this could be a unique setting where no immune suppression may be needed. That, as I mentioned, in Fanconi anemia, the stem cells are fragile, so maybe we could use healthy donor cells that could outcompete the fragile Fanconi anemia stem cells. And potentially this could be a safe and effective way to also stabilize the hematopoietic system. And so this is a collaboration with our colleague Tippy McKenzie at UCSF, where she had a prior clinical trial in an inherited blood disease called alpha thalassemia major, where unfortunately fetuses have severe anemia and need blood transfusions. And in this clinical trial, she showed that one could do bone marrow transplants in a fetal setting and could do this safely. Although in this disease, she saw minimal efficacy, likely because the bone marrow is revved up in this disease, whereas we thought that Fanconi anemia could be a unique disease where we could leverage what they learned and showed in this clinical trial, but in a setting where it's more likely to work. Given again the fragile and failing bone marrow system that occurs in FA patients. And so we set up a model to try to replicate this. Again, our lab works on mice models. And so the way that we set this up is we set up FA carriers to FA carriers and had them make a litter of pups. These pups then have a different mix of either FA homozygous mice, which means mice with the Fanconi anemia disease, or carriers or wild-type mice. And then in the middle of the pregnancy, we did transplants from healthy donors. And excitingly, what we saw is engraftment in all of the mice, but in particular, the mice that were homozygous that had the FA disease, we saw much higher engraftment, and this engraftment increased with time. Again, we think likely due to the defect of the hematopoietic system in the Fanconi anemia disease setting, which then causes the bone marrow failure, but here gave an advantage to the donor cells. And we saw multi-lineage engraftment in all cell types, so all cell types now were from the donor. And excitingly, when we looked in the bone marrow, and now the stem cells on themselves were also now from the donor, and that these stem cells were now resistant to DNA damage, unlike the mice's original stem cells. And so again, this gave us reason to believe that in utero transplants potentially could be used in these patients that get diagnosed with Fanconi anemia during the pregnancy stage. We also showed this in another mouse model. The first work was in a mouse model of FANC-D2. Here, this is work in a FANC-A model, but again, similar findings. And then we specifically looked at whether we could see graft versus host disease, and we did not in these animals. And we also saw a more normalized immune repertoire, which was interesting as well. And so this is really what we're working on now, is to improve upon standard transplants, as I mentioned, but also to develop an approach that can be used in the prenatal setting, to be able to do in utero transplants for patients with Fanconi anemia, and that get diagnosed during pregnancy. And so the way that we're planning for this is to be able to obtain bone marrow from the pregnant moms, purify out the stem cells themselves, and then we hope we just need to do an injection into the umbilical vein that can be done under ultrasound, and that these stem cells can, from the umbilical vein, go straight into the baby's bone marrow and graft there, and then stabilize the blood and immune system, hopefully through this overnight hospitalization or outpatient procedure. But that would be it. No need for any chemotherapy, no radiation, no antibodies even, but hopefully do unconditioned transplants given the unique disease biology here, and the unique way of taking advantage of the fetal system before the immune system builds. And so we're working with our maternal fetal medicine colleagues and transplant colleagues at both Stanford and UCSF to be able to translate these results through a clinical trial that we hope to open next year, again, to take care of patients who are diagnosed prenatally and hopefully develop an alternative approach that could also be safe, effective, rapid, and relatively easy. And then the last thing that I just thought I would touch on is some of our work on trying to do in vivo correction. So there's also different groups within the field starting to think about, could we not even have to take out stem cells, fix them, or use stem cells from a donor, but could we just fix mutations specifically within the body and give gene modification approaches or gene therapy right into the blood system and forget taking the stem cells out in the first place? And so we've been collaborating with colleagues to explore this approach in mouse models as well. Initially, we've started by actually correcting a green mutation. So we took mice that used to be green and have expression of a green fluorescent protein through a transgenic means. We created a mutation that turns this green protein off. So we call these our GFB on model, because after we do the gene correction, they turn back to being green. And now we've been starting to explore different ways that we can give this using viruses or other approaches. And this is just showing that as a proof of concept, we can use a specific type of virus to now correct this mutation that turns off the green protein, instead makes it green again. And by delivering this virus directly into the blood in an in utero context, we're able to now correct the mutation, and you see green fluorescence in a variety of different cell types. Again, there are some challenges of using viruses. We're trying to understand that better, thinking about other approaches, collaborating with a lot of different labs to try to explore that. And then what will be really important for our Fanconi anemia setting is to really also be able to get into the hematopoietic stem cells themselves to stabilize the blood and immune system. And so we're working in that direction. So I think this might be a very forward future, but one that is starting to be developed. And so I just wanted to introduce that to the group as well. And so that's where we really are today. Again, we have a variety of different approaches that we've been working on to develop improved treatments for Fanconi anemia. We hope the learnings from this can be applied to sickle cell disease and other blood and immune diseases, and ultimately that we can have safe and effective hematopoietic cell treatments for all blood and immune diseases through these types of approaches. And so in summary, I just wanted to, again, share that I believe there's promising opportunities to use hematopoietic stem cells to cure many different diseases, both using cells from healthy donors through allogeneic transplantation, as well as using a patient's own stem cells that are gene modified as through gene therapy, and that these are not just theoretical approaches, but again, ways that are being used today. For Fanconi anemia, there's only one gene therapy approach, but for sickle cell disease, there's many others. Again, that we're hopeful that the future is actually being able to use non-genotoxic HSC-based treatments through different types of antibody approaches, either naked antibodies or antibody drug conjugates, that could be done and developed by different groups. And that in Fanconi anemia, in the gene therapy context, we might be able to do transplants without even any conditioning. And that we're also working on other innovative new approaches, including in utero transplantation for FA fetuses that are diagnosed prenatally. And that other approaches are also coming, including base editing and prime editing approaches or potential in vivo correction, taking out the transplantation process. So with that, I will stop and take questions. Again, Fanconi anemia has been kind of our core disease area where we've been trying to push for innovation and improvements of treatments, but we're hoping that a lot of the learnings can be applied to other diseases as well. And that there's a lot of different approaches that currently exist and approaches that are being created, which I think is important for the community to recognize. And hopefully we'll have even more safer approaches with time. And these are kind of the focus areas that we're working on. Again, I think we're just at the tip of the iceberg. There's still so much more to learn and to do, but we have been slowly marching away and making some progress. And we're also now continuing to work on understanding antibody conditioning, applying it, and then developing better approaches with time. Again, I get the opportunity to chat with everyone today, but this has really been worked through a collaborative effort with many, many different folks, different mentors, senior colleagues, collaborative labs, and then of course my lab has been involved in various different components of this. And I'm very grateful to all of the different institutions and centers and funding sources that have helped us, as well as of course our Fanconi anemia patients and their families who've been working with us to have their children treated. So with that, I will stop and I will take some questions from the group.
Thank you so much for this excellent talk. This was really exciting news, very new information, innovative treatment. I see some questions here. Someone is asking for the treatment that is given to the donor before and after the procedure. I guess the classical, the traditional treatment. You mentioned some of it, but please.
Yeah, so for the donor themselves, it depends on how we or what type of stem cells we use. So we are trying to use these hematopoietic stem cells, but they can be obtained either from the bone marrow or from mobilized peripheral blood or from umbilical cord blood. When we use them from the bone marrow, the donor is often given anesthesia and goes to an operating room, and then it's a procedure where the doctors collect the bone marrow by using needles that they poke into the pelvic bone and then aspirate bone marrow from there. And so again, the treatment for the donor is the anesthesia and the collection of cells is done that way. For patients who are donating via mobilized peripheral blood, they receive often these two drugs, G-CSF or plerixafor, which push the stem cells into the blood so that we can collect them through a procedure called apheresis, which is like donating red blood cells. But a patient is hooked up to an IV where we collect the cells that way. And then sometimes we use umbilical cord blood, which actually comes from babies when they're born. Often the umbilical cord blood is just disposed of as waste, but it can be collected, and that can be another donor source. In that setting, really nothing happens to the donor. Their umbilical cord just gets cut just like they normally would during birth, but the cells are collected. So those are the three most common sources, and that's how they're obtained from that donor to be used in the patient. And then for the patient, as I mentioned, there's a lot of different chemotherapy, radiation, antibody-based approaches that we use. And it's very tailored to each specific patient, to each specific disease. Each center does things slightly differently. But our ultimate hope is to change the way that we do all of this with much better drugs that are easier to use and more consistently used.
Okay. So do you still use bone marrow transplantation, or is not so often used anymore? I mean, mostly you prefer umbilical cord blood and peripheral stem cells, or do you still use bone marrow?
We still use different types of stem cell sources depending upon what's available, specifically for our patients who have matched sibling donors, where we don't, I think we need to do significant graft manipulation because there's a very low risk of getting graft versus host disease. In those settings, we still do bone marrow. But for many other patients, we do mobilized, or many other donors, we do mobilized peripheral blood. We really think about what type of donor is available for our patients as well. And different people have different types of donors, either within their family or within external registries.
Okay, thank you. There is also another question regarding what specific competencies do Nigerian nurses need to support patient education, consent, and post-treatment monitoring for gene therapy. This was also one of my questions, how LMIC countries can use this innovative treatment, but yeah.
Yeah, so there's a lot of different groups that are working on different types of gene therapy approaches that are at different stages of development. In sickle cell disease in particular, we're very grateful that there are several different approved therapies, at least available within the United States, that we're hoping will also become available in other parts of the world. And each of these products has their own specific ways of being used and specific competencies. But I think it's really important that patients learn about all of the different approaches that are available today and might be available, and having good consent processes with their doctors. And then doctors and nurses can really be involved in that, and creating additional education materials to make this easier for patients is really important, because these are very powerful procedures that can really help patients be treated of their diseases. But again, they can have various different toxicities, and they're very serious potential toxicities. So it's important to have those conversations, understand the risks and benefits, and make collaborative treatment decisions. And then again, the treatments themselves, we need different types of expertise given the way that they're done, which is still a technically complex procedure. So I think that there are different ways that the staff can learn about how to be helpful, but really we work in a team-based approach where all different aspects really try to be learned and taught and utilized as optimally as possible. And so I think developing gene therapy centers to do this is a smart way to ultimately be able to provide these types of treatments to patients. And again, hopefully with time, we have even better approaches that are easier to use that then can be used in more settings as well, because the way that we do things today is, again, still very complex, very resource intense, and is unfortunately not available in many different places all around the world.
Yeah. Thank you. There is also another question. How can high-fidelity, precise gene correction be effectively and safely performed in Fanconi anemia patient cells when the cells are inherently deficient in the DNA repair pathway that most classic gene editing techniques rely upon for precision?
Yeah, so we've been specifically using base editing approaches where the base editors are able to correct the mutation. And so we're actually not cutting the DNA. And so we're not forcing the cells to undergo gene correction in that context. And so by using some of these newer approaches, that could be one potential way. But that is a possible risk, and that might be also why it's an inefficient process. However, in our models of Fanconi anemia, we've been able to show that base editing can be a very effective way to correct the mutations. And other groups all around the world are studying this as well, showing similar effects. And in some cases, they are actually able to use more earlier versions of gene editing as well, despite these inefficiencies. And in particular, it's thought that if we can correct just a small number of cells because they end up being healthier and having a competitive advantage to the failing cells, that could be a way that still could be effective. So there's a lot of work being done in the field. We're comparing different approaches, but I think there's reason to believe that this kind of future could exist for our patients.
Yeah. Okay. And do you think that this new innovative treatment, the gene editing, will reduce also the secondary cancers that these patients developed, or only treat uh, uh, the bone marrow failure syndrome?
So I think there's a lot that we're trying to learn about that. Our hope is that they would be helpful in both ways. For our gene editing approaches, I think there's reason to believe that they would have a much lower risk of developing cancers within the blood and immune system because we've corrected these cells in approaches that seem to be fairly safe. Although, again, these are still new approaches and there's a lot that we're learning about them. And we are manipulating the genome within stem cells. But then it also depends on how we do conditioning in order to get the gene modified cells to engraft. So right now the gene modification that we've been working on is outside of the body in most cases. In Fanconi anemia, we believe that we might be able to get engraftment without chemotherapy, but in most other diseases, one still needs to use busulfan unless we can develop these types of antibody approaches. And again, we have a first generation approach that has been working in the Fanconi anemia setting, but we're not sure if it could work in other settings, and we might need more potent drugs for that, which again, different companies are working on. So I'm hopeful that we'll get there with time, but we're not there yet. So you could still get cancers from the conditioning itself. And then in Fanconi anemia patients, they have a naturally high rate of developing cancers. We aren't correcting the other tissues with our gene therapy approaches unless we can come up with in vivo approaches. And so that's why we're starting to think about, is that a potential thing that with time could be done? Again, the primary focus is trying to stabilize the blood and immune system, as that's a critical issue for these patients early in life. But in an optimal way, maybe we could correct every mutation in every tissue of the body, but I think that's a much, much further away future.
Yeah, probably in the future we will see exciting treatments. Yeah, new treatments. Okay. I believe there are no other questions, so maybe we can conclude. So thank you very much, Dr. Czechowicz, for that truly insightful and inspiring presentation and for sharing your expertise with us today. We also thank all participants for joining. So please meet us in the next session in a while. Okay, thank you so much.
Also, can everyone please complete the poll that has been launched before logging off, if possible, please, and thank you.
So, yeah.
Thank you, everyone.
Thank you. So in the meantime, maybe we can continue the discussion, I guess. For how long do we need to wait for the poll?
Just another minute or two, just
Okay.
majority of people. So 32 out of the remaining 39 have completed.
Okay.
So, yeah.
So
So people are slowly logging off. So I'll be in about a minute or so. I'll end this one. And then we have the plenary track that starts at 10 o'clock.
10 minutes. Yeah.
Yes.
10 minutes.
And then after that,
So-
there's a break. So everyone can get a coffee or anything after the plenary track.
Yeah, we're hoping everyone's really enjoying these sessions and learning a lot.
Yeah, I think there is a lot of interest, if I can see from the chat, and it's really amazing how the research has forward. I mean, in utero transplantation, it's like science fiction.
Oh, yeah.
But hopefully, this can be performed also in LMIC countries. I believe
sure.
there are
Great.
so many challenges. I don't know, what do you think? What is the most significant challenge to apply this treatment in countries with low resources? What is your opinion now, Professor Czechowicz?
Yeah, so, I think a lot of it comes down to how do we think about resourcing things optimally and getting access to things. So things that have commercial products or involve a lot of manipulation are more challenging, I think, to do in other countries, unless we figure out ways to do them easier or with less expense. With donor cells, the cells themselves, as long as the donor is willing to provide them, can be relatively easy to obtain. And so those types of approaches, I think, could be potentially easier to move forward with. Again, if we could develop safer conditioning approaches, maybe we could even do donor transplants in a postnatal setting in more outpatient context with fewer resources, fewer infections, fewer comorbidities. But it'd be important to then get the antibodies available around the world. But with the in utero approach, at least for Fanconi anemia, we think no conditioning might be needed. And so this is something that in theory, I think could be done in a lot of different places. The most challenging thing, honestly, is the diagnosis of these patients early enough, because that doesn't happen that frequently. We have had 8 patients that have come to us over the last few years with a prenatal diagnosis, but most patients are not diagnosed prenatally, but they can be identified due to ultrasound abnormalities, and then testing can be performed from an amniocentesis. But I'm hopeful that maybe we could have blood-based testing. Maybe that blood-based testing could be used everywhere, but I think we're still very, very far away from that future. And that might be actually the biggest challenge. Is not the collection of cells, it's not the transplantation itself, but it's really the identification of patients in that setting. And so more work to be done there.
So probably in many countries, these patients remain undiagnosed. Probably they die without being diagnosed.
Probably. But I think, we're working on improved approaches. If there's a family history, if someone in the family has been diagnosed, I think that makes people more aware that they're likely to be carriers. And so those types of patients, for example, could be screened. And then the hope is that we can learn a lot from our in utero transplantation and Fanconi anemia settings to then think about how you could apply it to other disease settings. Again, Fanconi anemia has some unique biology that leads us to think one can do this without conditioning, but there are other groups that are working on conditioning for in utero transplants as well. And so maybe something like that could come so that it could be used for other inherited blood and immune diseases in a prenatal context as well.
That's a great response. But now I'm going to have to end the session. So I'll see everyone in the plenary.
Thank you so much.
Thank you so much for everyone, to our lovely moderator and speakers as well.
Thank you.
Thank you so much. Bye.